Dr. O'Connell is still a practitioner with the outreach team on the streets of Boston, who manages clinical hospital-based programs and is an advocate for public policies and programs to address the needs of people who are homeless and marginalised, both on the streets and once they're housed. Dr. O'Connell is also very involved in health reform debates and discussions in the USA. Please join with me in welcoming Dr. Jim O'Connell.
Thanks. I set you up, didn't I? Okay, thanks. Thank you very much, and I hope this will be, you can hear me okay. First of all, since I flew from Boston to Houston to LA to Sydney to the Gold Coast to here yesterday, it's actually great to have had a night of sleep, and I'm thrilled to be here. And I also want to just say, as always, I feel like you've welcomed me as part of your family, so thank you to Karen and all the folks at Micah, Felicity, who I've seen now in so many different cities, and to so many others of you who I sort of feel like I've been learning and growing with you during these last few years, and it's been a real pleasure. And whenever I get out of Boston, I'm thrilled, so thank you very much for that as well. I wanted to share with you some of the experiences we've had in Boston, and what goes through my mind is Tip O'Neill, who used to be the Speaker of our House, who was from Boston, used to say all politics is local. And so when I share with you what we were doing, believe me, I think all healthcare is local as well. I think Tam was saying that, and I was learning that. And so some of the lessons that we learned, I think we learned because we had to. It's what the healthcare system looked like in our town at the time we were doing it. But I think there's probably some general lessons that we can share with each other. And stop me at any time. I'm just going to share with you some of our experiences. And I wanted to start for the first sort of 10 minutes and just give you a little hint of what our program is like so you have a background to it. Then I'd love to share with you much more specifically work that we've been doing with our rough sleeper population, both housed and those who are both on the street and those who've gotten into housing. So this slide I tend to begin with because you have to picture this. I went to medical school and then did my residency at Mass General, and I was a senior resident at Mass General. And my last job there, when I was finishing, was to run the ICU. So I was running the medical ICU. I thought I was as good as they got as a doctor, right? And I was, after all that 7 years of training, you get this hyperinflated ego. I know there are many of the physicians out here, we know this well. But that's before we hit the real world. And what happened to me is I got recruited, which is a euphemism for saying told, to go work in this new program that was starting in Boston, and they needed a full-time doctor to help work with it. And so I went down to Pine Street Inn, which is about 6 blocks down the road from where Mass General is. And I had been, all during my residency, been thinking I was sending people to an inn. So Pine Street Inn is actually a big shelter, but it sounded like an inn. It sounded like people had a nice place to go. So I would happily write all these treatment programs thinking they had a place to live. So I went down there and I thought, boy, they'll be thrilled. I'll be the first doctor working in the shelter, and it was kind of, it was my first job as a doctor. And I have to also mention, I didn't get to medical school until I was 30, so I was pretty old by this time, and I was thrilled to finally have a job. But I walked in and the nurses were really, how many nurses are here, by the way? Are there many nurses? Oh, fabulous. So this is actually really a tribute to your work, and it's the nurses, I think, who can really teach us all a lot about what we need to do. So I walked into Pine Street, and the nurses sat me down, and they said, really, I have an older sister who's a nurse, so I know the grim look of a nurse when I run into it. And they said, look, we've been taking care of homeless people for about 15 years down here at the shelter without the help of doctors or hospitals, thank you very much. So just sit down and we'll tell you how to do this. So I'm coming, 100 miles an hour from the ICU, ready to get to work. And they told me to sit down. And I had to do nothing but soak feet for 2 months. And you remember, I was dialing it, I was doing PA lines, chest tubes and stuff like that, and all of a sudden I'm soaking feet. And Barbara McGinnis, who was the head nurse at the time, who was my hero, sort of sat me down and said, look, what you've got to do is slow down. Nothing changes in the life of a homeless person until you can earn their trust, be present, and be of service to them. And so she made me soak this man's feet. He was one of them. This was a man I had known from the emergency room who had hundreds of emergency room visits at our hospital. And we knew him back then as, in his chart, it was written schizophrenia, paranoid type, treatment resistant. And he would be brought by the police into the emergency room. We'd sit him in a room, try to talk to him about what he should do. And he had these terrible swollen feet that were always getting infected. We're trying to say, you gotta get off your feet. You need to take your psych meds. And he would never do anything we said. He'd look at us with that look and just leave, and he'd be back in another day or two. So I had to soak his feet at the shelter. And about a month after I was soaking his feet, he looked down at me and he said, "I thought you were supposed to be a doctor." And I said, "Wow, I am." That's the first thing he ever said to me. I said, "I really am." And he said, "Well, what the hell are you doing soaking feet?" And I told him I was doing what the nurses told me to do. And about a week or two after that, he said, "Doc, I'm having a lot of trouble sleeping. Can you just give me something to help me get to sleep?" And this was back in the days when I could give him a little bit of Haldol because it was a good sleep medicine, but it also might help with his thought disorder. And he came back 2 nights later and said, "That was pretty good. Can you give him a little more?" And that was the initiation into him deciding he wanted to take medication and doing it on his terms. But it took 2 months of soaking feet to get to that. So I kept thinking at our Medicaid world, we have to do visits, and you have to say your visit was 10 to 15 minutes, 15 to 30, or 30 to 45. So I tried to put a little check mark that said 6 months or 2 months, but didn't get paid at that rate. But it was the lesson that the nurses shared with us, that things don't happen unless you have a presence and unless you can establish a relationship with folks. Otherwise, we think of them as not willing to do our services. So in Boston, we had to come to grips with how do you, see if I can do that, how do you bring a healthcare system to bear on a group of people that just are struggling to survive every day, and healthcare is so far down their priority list that they're not, they've got to find a meal, they've got to find their next bed. They're not going to go take care of their blood pressure or their hypertension or their diabetes. So we were hoodwinked also because it was the group of stakeholders, homeless people, homeless advocates, nurses from the shelters who put together the grant that would decide how we would look. So I take all of what I'm telling you is decided for us. And the mayor of the city of Boston, who wanted this grant badly, was willing to listen to the community. And what they said is they wanted a service delivery model that provided continuity of care. And I want to share that with you because continuity is really the name of the game. And it's very difficult when you're dealing with populations that are moving all over the place. But they were sick. They wanted continuity. They wanted to make sure we could take care of them in a shelter on the street. When they were sick enough to be in the hospital, we could take care of them there. But then when they went to a respite program or went on afterwards, we would continue to be the continuum of care. They also want to emphasize in continuity. They said you have to work in teams. And this has struck me because one of the themes of our program has always been to work against what I was trained to be really independent and take care of your patients, and to work always in a team where every patient that I take care of also knows the nurse practitioner I work with, the physician assistant, and the psychiatrist and everybody else. So that person, if I should leave, has plenty of healthcare providers that know him or her well. And that was what they were saying. This is 1984. Okay, so go back. This is just before we started. And the last thing, which I'll talk about in a minute. Can I move this up here? Does it work up here? If I could do this, it might be a little easier. Sorry, because I'll never do this if I go there. So these are the people that put it together. So, and I also would emphasize to you, if you can, and I would I can't tell you how valuable this is, but we were put together by a group of community stakeholders that were home. These are the 4 of those people are homeless and using our service. One is Barbara McGinnis, who was the nurse who was at Pine Street Inn Shelter. And they were the group of people that put us together, became our consumer advisory board. 5 of them are on our board of directors. So our bosses are technically the people we serve. And in our country, that's at least when I come out of a hospital mode, that's not usually who it is. Usually the hospital board is a bunch of people who are very good-minded and have money and connections, but they're not the poor people you're serving. So I look at that picture and I cherish it because all of the people in that picture are now dead, but they were the people that really formed our program. And Barbara is the one third from the left is Barbara McGinnis. And the woman far on the right was Ellen Daly, who was a phenomenal patient of ours who went on to found a national consumer advisory board that is now still in existence. But this is what Barbara said, and it's the theme of our program. If you wait for people to come to you, you've already lost. Okay, and that's hard for us to hear when you work inside a clinic or in a hospital, because you want to say people have full access to us, bring them in, we'll take care of them. And we were trying to make all of our main sites accessible to people. But in fact, if you're talking about that segment of the homeless population that's living rough on the street, it's very difficult for them to do that. There's all sorts of reasons. I don't need to tell you, you know the litany of reasons why they won't. And so what the nurses were saying, Barbara, is that you got to get the clinicians out of your spots and get out to where people are so you can get to know them, get to have them win your trust, and then you can start to take care of them. So the challenge for us has always been, how do you get out there? It was a little thing I threw in here that the nurses were also, not the nurses, but the community was so chary of the medical establishment, us, that they said that if they're going to go along with this grant, they did not want anything that smacked of charity. They were sick of having charity. They wanted social justice. This is also 1984, and they did this with a legal firm. And so we couldn't use any volunteers. And I have to tell you that when I took this job, I had every friend I had, all the people I had trained with, the people going to subspecialties, all ready to volunteer and help out. And the community said, that people we were serving said, no way, we don't want any volunteers. We want full-time people. If you see me on Monday night and I get sick on Wednesday, I want to know I can pay you and you're going to be there. So we've had this problem that we've had to deal with ever since we started, that we have to be on call for the people we serve 24 hours a day, which is what most practices will do. And so homeless people were saying we deserve the same thing. And that was part of the continuity. There are other things there that I'm going to, by the way, after we got everything sorted out, they now let us use volunteers and we can do stuff, but we needed to set up an infrastructure that they could depend on first. This is just my nostalgic slide to show you. This is Boston. It's a very tiny little city, but it has a huge number of hospitals and academic health centers. There's 12 major teaching health centers in that map, which is 2 miles by 2 miles. It's all of the Harvard teaching hospitals, the Boston University teaching hospitals, and the Tufts teaching hospitals. In addition to that, there's 26 really good community health centers, and it's all in that little map. And when you think about it, why then, in a city like Boston, would you even need a homeless program? Because you've got all of that, probably the richest healthcare mecca in the world. But it turned out that in the shadows of our buildings, much to my embarrassment, were living people that were getting basically third world care. And it was a huge embarrassment to us, and to figure out how do we reach out to that group who's right there in front of us. So what the community made us do is stay part of the hospital. I was thinking about this when you brought up that question, Tam. We had to stay part of the hospital because that's where homeless people were at the time in 1985. That's where they were going in droves. The reason we got set up is because they were coming into the emergency room with problems that should have been done in a primary and preventive care mode. And what we had to do was get out there and start to do that and try to help people not to go to the emergency room but to come to us. But we had to have a clinic at the hospital. This is Boston City Hospital, which is now Boston Medical Center. And the other hospital we have a clinic every day is Mass General Hospital. So we had one big private hospital, a Harvard Teaching Hospital, and the City Hospital that we would have our docs and our nurse practitioners and PAs doing their clinics in, so that we would be part of the mainstream. Because one of the uphill battles we all fight is how do you make sure you're not marginalized by the very professions and people you're trying to work with. You want to stay part of them, take care of a very vulnerable group, but do it in a way that you're still part of the mainstream. This is Pine Street Inn. I thought I'd show those for those of you who've never been to Boston. That's our New England's oldest and largest shelter. It gives you a flavor for what our adult shelters are like. It's a beautiful old building, but it sleeps about 500 or 600 men in that building. There's a women's building which has about 150 women that sleep in it exactly adjacent to that. And then with all the other programs, Pine Street is now getting into housing. They do these phenomenally wonderful different programs. They sleep about 1,500 people a night, so it's a relatively large facility. The city shelter, and Karen was talking about this earlier, the city shelter is an interesting thing. It's out on an island called Long Island, and I'll show you a picture of where it was in a minute. Because when Pine Street was so full in the early 1980s, they pleaded with the city to come up with another shelter because they couldn't handle everybody. The mayor couldn't find a neighborhood that would take it, so he found there was an island where we had an old building. This building right here was empty out on the island, and so the price he paid was he buses people from the downtown, from the city hospital, 10 miles out to this island every night. So there's about 1,000 people that sleep on the island. This building, by the way, was empty at the time because it used to be the TB treatment building for the city of Boston. It was out on an island where you expect to get air. And it was empty because we had instituted pretty good public health controls to take care of TB as a public health problem. So then we stuffed it with people in the shelter, and surprise, surprise, about a year later we had a huge tuberculosis outbreak in the shelter, as many other shelters around the country did. So don't let that irony escape you that most of our shelters in America now, the big ones, are former mental health hospitals that were emptied out during institutionalization, and then we put people with lots of mental illness in them as shelters, and then another one is the TB sanatoria. It's kind of an interesting indictment of our system. But this is the island right here. So you can get a flavor. You get a flavor that people are bused from where it says BMC. They're all the way down there each day, and it's really a gas. And it looks beautiful. If you want to go to an island, this is looking back at downtown Boston from the back of the shelter. So for some people, this is a delightful excursion away from town. For other people, they feel like it's Molokai, that it's, you know, you've been exiled as a, you know, as a leper of our modern society. So it kind of is interesting. So I'm skipping over something, but when I started doing clinical stuff, remember I thought I was good, and this was a story of somebody I had examined and seen and thought was maybe a little bit sick, but not that sick, and the staff at the shelter kept saying, you know, Doc, this guy doesn't look good. Remember, I'm coming out of the ICU and I am good. So I said, nah, he's okay. You know, his vital signs were normal. When you listen to those lungs, for those of the doctors in here and nurses, they were clear. And that's tuberculosis. That was cavitary multi-drug resistant tuberculosis in 1985. It was the first case of what turned out to be 100 cases of active TB in Pine Street in itself. And because it was multi-drug resistant, it required 4 drugs every day for 18 months to take care of. And that's when we first started to realize that you can't take care of this population if you think, one, like a doctor taking care of a patient. You have to think like this is public health, that every patient you take care of is also going to have a big effect on others. And you have to go out to get them. So this is a picture of Barbara McGinnis. I'd like to show this because she was a public health nurse at the shelter, and that's how I got to know her. And that's Yoshiko Van on the left, who was a nurse practitioner who was my teammate for 10 years. And what we had to do is, it turns out people who got tuberculosis, all 100 of them, about 60% of them said, God, I got TB in the shelter, and they just headed for the streets. They did not want to be back in that shelter. So we had to go around on our bikes every day and find these folks with the department. We learned we were only as good as the Department of Public Health helped for us, the city and the state departments, and the nurses at the shelter. So we all had to collaborate to figure out how to get 4 medications to each of these people for 18 months. It was a huge effort, okay? But it was 1985, 86, when we were just learning what we were doing, and it taught us we had to get on our bikes and get out to where people were, or else you were never going to treat it. This, by the way, was the first case of sort of modern MDR, what we call multi-drug resistant tuberculosis, and this is the beginning of what they call now directly absorbed therapy, DOT. And it was a model that one of my friends, whose name is Paul Farmer, and another doc named Jim Kim did this in Peru and Rwanda. They used the Boston model to do in third world countries. It's kind of an interesting thing that inner city medicine sometimes looks more like third world approaches than it does like modern approaches. In the shelter, we had to learn that there's all sorts of things you have to be around for. This was a man who was 88, who I thought was outrageous. He was older than my grandmother at the time. He had been in the shelter forever, and so I figured out how to get him into a nursing home, and I found the best nursing home, did all the paperwork, which in our country used forever. Got him to the nursing home and put him in his bed, and I was so proud of myself, and I'd done all that. But as it turns out, that's not what he wanted at all. It was what I wanted, not what he wanted. And I came back to the shelter about a week later, and he's back in his usual table, holding cord in the thing, and I said, I was ready to kill him. I said, Leo, what are you doing? And he said, hey, Doc, come on, give me a break. I've been here for 25 years at the shelter. These are my folks. He said, you put me in that stupid nursing home, and everybody's sitting around fixing to die, and nobody's talking to one another. I don't want to be there. So he came back and he stayed in the shelter until he was 93, when he had a seizure one night and died from a seizure. And I had to kind of learn to let go of that. So what I would urge you to say, sometimes what we think is good quality medicine, when I'm thinking of it from a overall thing, is not the quality that you're going to be looking for in the folks who are taking care of. What the goal of it is to find out what people want, and then how to best get for them what they want. Just another funny story to tell you really quickly. This was another man who taught me that sometimes what I want isn't what they want. But he came in one day and he said, Doc, I cannot swallow my vodka. And I was like, what do you mean? His name was Amerigo. And he said, I can't get this vodka down. He tried to show me he went to swallow it and it wouldn't go down. And when I got that story from him, he had not been able to swallow food for quite a while. But now it had gotten so bad he couldn't even get the liquid down. And he would come to see me because it was the vodka that was really important to him. The food he could live without, but the vodka he couldn't live without. So it turned out he had a huge esophageal cancer right in the middle of his esophagus. It was not operable at the time. It was really beyond palliative care even. So we had to just put a tube into his stomach, a J tube we call it, so that we could feed him that way just to keep him with food. And then I also got him a place where he could go die in comfort and dignity, and we spent a lot of time on that. And I came back to the shelter about a week after that, and he's out in the outside of the shelter. He's out, talking with all his friends, and he's got that feeding tube here with this thing, and he's pouring the vodka right into his feeding tube. I wanted to kill him too. I said, come on, Amerigo. And he went, Doc, come on, I'm dying. This is what I like to do. Please let me die the way I want to die. And I had to like back off and realize that the stuff that was in my mind of how he should have a good death was not what he really wanted. And believe me, I'm coming from a world where we usually know what's best for people, so you catch me on this. It was a real lesson for me. The last thing here, which I just want to share with you really quickly as a background thing, is see that last thing was establish the capacity for respite care. I didn't know what respite care was at the time. This is 1985, and we have in our Medicare world, we have respite care as when you are taking care of a sick, older adult or someone, a family member, and you as the caregiver need a respite. They'll pay for someone to come in and give you a break so you can do something. That's what Medicare in our country hears as respite. But this is medical respite care for homeless folks. And what the community wanted was a place where people who, when they were ready to be discharged from the hospital but didn't have a home to go to, but were way too sick to be out in the streets and in the shelters where they could go. And respite care has become a real issue in our lives, which I just share with you. We started out in 1985 with these 25 beds in a shelter. That's Betty Sneed, who was our first respite aide. And we would take care of people who had usually been in the hospital for 4 or 5 weeks. We kind of laugh. When I was a senior resident at Mass General in 1985, if you had open heart surgery, coronary artery bypass, the average length of stay back then was 5 weeks in our hospital, and now it's 3 days, okay? So homeless people got really nailed in that drive to shorten hospital lengths of stay and shift the locus of care from the acute inpatient setting to home settings and community settings. And we found that homeless people just got sicker and sicker and were coming to us in different ways. So we started to do this. We worked on making respite care more and more acute. So this is an example. This is Ernesto Gonzalez, who's a dermatologist from Mass General who comes every week and he sees anybody in our respite program. As you can see, our staff is around it because we're all hungry to learn from the dermatologist because we all have our own skin diseases we want to learn about. But he is, and fabulous. He's been doing that for 25 years. This is a man who has frostbite. He has schizophrenia, lives on the street, got frostbite, lost part of what's called a TMA, a transmetatarsal mutation. We would do the wound care for him after he finished his thing. And our nurses at the McGinnis House are really fabulous. I thought I would show you a benign picture. This is early frostbite, so if you ever want to know what frostbite looks like, I thought you would never have seen one up here, but maybe you have. But this is before it turns black. Okay, it looks like a burn when you first do it. And we see at least 8 to 10 cases of people losing digits, toes and fingers each winter time, and it's a horrifying experience. These are usually young people who are waiting for these black fingers to fall off. They have to auto-amputate. You can't do the surgery first because you don't know how much viable tissue is under. So it's somebody losing real parts of their body for something that was entirely preventable. Okay, and it's just horrifying. And I could, if we were a medical audience, I'd show you some really gross pictures and what happens over time and how horrifying it is, not only for the patient, but for our staff. It's really tough. So a woman with the physicians in the owner who had relapsing polychondritis. She was in the shelter, and her trachea would collapse each night. She'd go to the ICU and be back to the shelter, back and forth, and so we could finally bring her to McGinnis House and take care of her. And then this woman is the woman that I cherish, and I usually include this in every talk I give to keep myself grounded. But she was in our McGinnis House and we let her stay for 6 months because she had hepatitis C and cirrhosis, and she needed a liver transplant in order to live. And we kept her there because in our country, I don't know how it is over here, you have to show residential stability for 6 months as well as sobriety. You have to show that you can stay clean and sober. So we let her stay in McGinnis House so we could give the transplant surgeons the weekly urines, and we could show that she had some residential stability. We worked on her housing during this time. But she called me in one Sunday and said, "Hey Doc, will you just take my picture?" And I had this, it was interesting when Felicity was saying that about when we do the vulnerability index and do the registries, we take pictures, or they've been doing it. And at first I thought that sounded incredibly invasive, but this is a woman who told me that for some folks it's quite the opposite. So she wanted this picture taken. She was a street lady who usually wore rags. I'd never seen her dressed up. She got to put a dress on. She has lipstick on. I don't know if you can appreciate that from where you are. She's got flowers in her styrofoam cup at her bedside table, and she's got nice shoes on. And so I took that picture and I, made a 5x7 of it, brought it to her in a little frame a couple of days later, and I said, "Hey, what's going on?" And she said, "Well, Doc, I've got 2 daughters that I haven't seen since they were 3 and 5 years old. And they're both in their early 30s now, and I'm worried if I go to this surgery and I don't make it, I want to be sure there is a picture of me, something left behind that they could look at if they're ever interested in what their mother was all about." and she wanted to look nice for that picture. And I was kind of stunned because this whole experience, if you crawl out of it, the experience of illness and suffering and facing death when you've lost everything, even your kids are not talking to you, you burned your bridges, is really profound. And I think sometimes when we think of this population, we don't realize that how difficult that would be. I think I have friends, when you get your cancer diagnosis, it's terrible even when you have a huge supportive family. But imagine when you get your fatal cancer diagnosis and you don't have a single person in your life that takes care of you or cares about you, or that you know of that cares about you. What was interesting to me is the next day I came in after I had given her that, and there were 22 people in McGinnis House who asked me if I would take their pictures. And it turns out it's a big issue. We have now in our McGinnis, in our program, we have portraits of everybody up on the walls. And when people come in and they don't have their portrait, they beg to have it done so they can have it up there. And it's all about making a mark, showing, you've been through this way and something to show for it. So we now treasure pictures. For those who want it, we will actually make sure we blow them up, we will put them in frames, give them when people get moved into housing. We always bring pictures with them so they have pictures of their lives. And it's a pretty profound thing to do once you get to know someone. The other thing at McGinnis House that I'd share with you is that many people, when they're dying, have no place to go. Just like when I sent people to nursing homes, they would go from where they knew the nurses and knew the staff to a nursing home where they didn't know anyone to have have hospice care. And they felt like we were abandoning them when we did that. So at McGinnis House, the respite program, where we now have about 104 beds, and it's 24-hour nursing and doctor and every other care, we will do end-of-life care, even though it's pretty tedious and tough. And this is Tommy on the left there, who is this fabulous guy who's 83 years old when I took this picture. He's dying of a neurological cancer. And his roommate, who's only 37 years old, with whom he bonded in this very remarkable way, is 37 and has lung cancer that's metastatic to his brain. And they each have about a 3-month at best prognosis. But they're in the same room and they're talking to each other about dying. It was pretty interesting thing. Now, Tommy was fascinating to me. I got to know him when he worked at this racetrack. We have a thoroughbred racetrack in Boston, where one day we were assaulted by this man, whose name was Jim Green, saying, you guys are supposed to be taking care of homeless people in Boston. How come no one's out here taking care of these 500 people, taking care of horses and living in our back barns? It was basically we didn't know it existed. But on every thoroughbred track in the country, if not the world, there's a bunch of people working behind the scenes who work 18 hours a day, get their paid under the table, and never ask for a handout because they're working hard. But they can't come to an appointment because if they come in for an appointment, they lose their entire day's wage. So this guy, Jim Green, convinced us. We all went out there. This was the horses looking at me weird because I wondered why I was taking the picture at the stable. And the stable across from that is where there'll be, in each stall, there'll be 6 or 7 people sleeping, and that's where they live. So we have a clinic out there. This is when we do rounds. We have to actually do rounds right while they're working. We have a little trailer we put on there so we can take care of them. And this is where Tommy worked from the time he was 18 years old until that picture. And when he was dying, we would bring him out in his wheelchair to see the horse. He was, his life was horses. And this was a filly that, we would bring him in when he was really failing, and the horses would all start screaming when he came by because they were all appreciating him so much. It was really a touching, unbelievable story. He died about a week after we took this picture. And this is our current McGinnis House, and I'll stop talking about respite care, but I would simply urge you, if you've got a chance, I know we were talking about subacute care, I think there's a huge need for, but very difficult to fund, someplace where homeless folks who are way too sick to be outside can go and be taken care of in a way that doesn't require all the costly stuff of a hospital, but does require a lot of medical and mental health and substance abuse support. So our program, just to finish with that and talk to you about what we're doing, is it's basically a freestanding homeless program. We've grown over the years. We have our teams of doctors are in about 70 clinics around Boston, 2 hospitals, 70 shelters, soup kitchens, Racetrack, all the places you can imagine. It's all on a single electronic record, which Mass General did for us back in 1996. And we have a lot of staff now, which is kind of embarrassing. We started out with about 2 or 3 of us, and we now have 17 docs and almost 40 nurse practitioners and PAs. PAs to us is physician assistants. I'm not sure you have that here, but they're sort of the equivalent for us as nurse practitioners, and a bunch of RNs, as well as dentists and psychiatrists. Anyway, we serve about 13,000 different homeless people in any given year now. But this is a picture. Let me diverge now and get back to the topic. So with that background, this picture was taken by a patient of ours, and it's the reason that we got involved with the vulnerability index. I happened to be giving a talk in New York one time, and this picture is always kind of stopping me on my tracks, but I showed it at a time when we were at a meeting, which was at Roseanne Haggerty's place in New York. And it was a picture taken by a patient of ours, our street team, who lived under the Longfellow Bridge right near Mass General, and these were her street folk, her friends. This was her group, and there's a bunch of like 11 or 12 guys there. There's one woman who's hiding, so she's not in the picture. And these, I can tell you this, these are all our patients. So these were all part of people that we considered very vulnerable, living on the streets. I could tell you all of their stories and all of what's going on with them. And they're sitting in a park that's on the grounds of Mass General Hospital, so near a good hospital. All of them, just so you know this is not an issue of insurance, all of them have good, what we would consider Medicaid insurance. Medicaid is our best insurer for poor people at home. All have Medicaid. And the drama of that picture was that 5 years after that was taken, there were only 2 of those people still alive, even though their average age is about 38, 39 right there. And it stunned us because we thought we were taking good care of them, and they were dying in numbers that we could not believe. And that's what started us on this journey of, how are we going to do something about this? But the street folks in America tend to be the ones that get pictures on the paper all the time. They're the most highly visible. And what we ended up doing is, this is the team, although our team has morphed a little bit now, and I should need a new picture, but we actually decided that if we're going to really go out to where people are, and we already had the shelters had some outreach teams out there. What they didn't have was clinicians outside, and we had already learned that getting clinicians into the shelter was a huge bonus. So we figured, how do you go out and take care of people in the streets, since they're the ones who are dying, so how do we get out there? So there's 2 internists. There's Cheryl if I go from left to right, Cheryl's a nurse. Pat Perry is an internist, along with, in front of him with a hat on is Jill Roncarati. She's our physician assistant. Myself, there's a LICSW named Kendall there, and Eileen is our psychiatrist. And our job, remember, we're paid. This is not volunteer. We get paid to do this. This has been my full-time job since 1985, but I get paid. It's not like I'm volunteering. And our job is to get out to where street folks are and figure out how to take care of them, but to work together doing it. So it was our chance to be sort of fully, in our world, kind of integrated. Because it didn't work for us if I was seeing somebody outside and they needed mental health services, and I'd want them to go over to the mental health clinic, which is far across town, where they'd see a social worker first who might or might not give them an appointment 3 weeks from then with a psychiatrist. It never worked. So we figured we'd better work together. And we sort of work at nighttime. There's a van that goes out all night long. So 2 nights a week, we're on the van that goes out from 9 at night till 5 in the morning. It's kind of an interesting thing. These are the folks that drive the van, and it's an experience. If you've come to Boston, we'll have you join. But these are the real heroes in the world. They are out every night of the week, 7 days a week, 9 at night till 5 in the morning, and they bring soup and sandwiches and blankets to the people who live outside. They know everybody, and they can tell you all about everybody. So I ride with them on Mondays and Wednesdays and can piggyback on the trust they've earned, and then get to know folks that way and let them know I'm also a doctor if you need anything. So we see this man who lives all year long on this bench at Copley Square. Other people, this is a cold winter night, this guy is a guy named Richie, just falls on a park bench, we'll catch him there. A bunch of people live up under bridges in places you would never imagine. These are I-beams that support a bridge going over Storrow Drive down by Fenway Park where the Red Sox are, and you probably can't appreciate, but there's boards across under there, and people crawl up and live under the I-beams, completely invisible to most of us passing by. There's an example of one of them, Cheryl trying to get sandwiches to one of the guys who lives up there. And then we also learned that because people live outside and it seems like it's chaos, many of them take their medications just as faithfully as I can take medicines. I'm really bad if I get 4 times a day medicines. I'm sort of I can get it about half the time. But many people outside do take their medicine. So we learned we can't just say because they live outside, we're not going to prescribe heavy duty stuff to them. And many of them, for example, this woman who I always laugh at this picture because that's lactulose, which she needs for her cirrhosis so that she doesn't get encephalopathic and she doesn't like that feeling. But you have to take it 4 times a day pretty religiously. It's ugly, awful tasting stuff. But she lives under that bridge. She will take it 4 times a day religiously. And I can get there some nights and there'll be a yellow sticky, models go yellow sticky saying, please refill, like 2 exclamation points. So she's really into it. And we've learned you just have to take each individual person as you will. We skip over that story, it's a long one. Now, when we were outside, we also learned that using your consumer and your advisory board and the consumers on your board is sometimes invaluable. And what we've got challenged a little bit is when you're outside as a doctor, and I was, or with a nurse practitioner, at 2 in the morning, we're waking somebody up who's sleeping under a bridge. Somebody said to me, how would you like it if your doctor showed up in your bedroom at 2 in the morning and just woke you up to see if you're okay? It's pretty invasive stuff. So we got really nervous that maybe this isn't the right way to do care. And we went to our board, and they called together. They had a focus group of all the street folks who were at McGinnis at the time, at McGinnis House at the time, about 40 of them. And they met for 2.5 hours, and they came out with this kind of interesting thing where they overwhelmingly said, look, if we're out there and you are, please wake us up, just make sure we're okay. So that was really clear. They wanted that. That was great. The thing that they beat us up for was that we always often had these flashlights, and we'll go out looking for people with the flashlight. They said, well, you take the damn flashlights, though, and shine it on your face, not on ours. So when we're out now, we have to keep the flashlight on our face so they know who we are, not who they are. And it was a pretty fair compromise. But the consumer board is actually really fabulous. And I could go on and on about how you can, almost any new project we've tried to do, we have to get it past them. And they are tough. It's really wonderful. Now, so what we also have to do during the day is this is where rounds happen in the day. So this is Pat and Jill. Pat's our internist, and Jill, one of our physician assistant, one of our nurse practitioners. And Monday, Wednesday, Friday, we do rounds at Finagle a Bagel, which is a bagel store right at the middle of downtown Crossing. And it's where we go, and the man who owns the store is fine with us doing this. But everybody on the street knows we'll start out there. So from 8:30 to about 9:30, we'll be there, and then we just head out. The important thing about heading out is that we sort of have grown to know where people are around Boston. It's small enough that you can walk during the day. In fact, the traffic is so bad, it's quicker to walk over across Boston than it is to drive. But we'll do things like see people on the common. I'm sorry about this picture of me, but what's cool about this that I cherish is that I work arm in arm with a psychiatrist. So I'm an internist. I know internal medicine relatively well, not as well as I thought back in 1985, but still relatively well. And Eileen, who's standing there with red hair, is a seasoned psychiatrist. She's been taking care of homeless people with us now for about 15 years, and she's really good. And I learned more psychiatry in the last 5 years of working arm in arm with her than I learned all during medical school and residency. But it's what these folks need. They all are suffering from major medical things like diabetes, but it's their thought disorder that's getting in the way of their treatment, and we can sort of combine forces to try to win them over. This is Jill, and there's just sort of the street outreach that we end up having to do. That's Eileen. She will frequently just sit and have cups of coffee with people. That's how she'll get to know them, because sometimes it's hard to, to sort of establish that trust. We have a problem with our own Department of Mental Health is if you don't show up to an appointment for 3 times, they say you no longer are eligible for services. And most of the folks we have would never make appointments, so they're all left outside, and DMH says they're not eligible anymore. So we've learned to do, as we did with that first guy who was soaking feet, is it takes time sometimes to win that trust and win them over. And last quick story about why that's so important. This is Mickey, who works in the outdoor market. He's been homeless and sleeping on Commonwealth Avenue ever since I started in 1985. And he now has a nodule on his lung that we don't know what it is. It's probably cancer. And I told him we have to stick a needle in there to find out what kind of tissue it is so we know what it is and how we can treat it. And how we treat it is going to depend on what the tissue says. But he went, are you kidding me, Doc? Nobody's putting a needle in my chest like that. And he's just paranoid, and he gets anxious about that. So we could sit with Eileen, who's a psychiatrist, and that's Pat, who's the internist that works with me, and Cheryl. We would sit down right at McDonald's, which is the place right by where he's working. We'd have coffee several mornings a week talking over what we could do. And Eileen turns out to be brilliant about getting through some of this paranoia in a way that I would have no clue to do. But she was able to convince him, with the promise of a lot of benzos and pain medicine, to take, to have the needle biopsy done. It showed cancer. We ended up doing the surgery to remove that part of his lung. And this picture was taken about 6 years ago now, so he's effectively a cure. But what I know clearly is that if we hadn't been working together, he would never have gone through that, and he would be dead of his cancer by now. So there's a huge, I think, compelling reason, aside from all the other things, to be able to work together and be able to go to where people are and talk to them on their terms in their territory, particularly within the people who have run away from stuff. Okay, I don't think this needs to be with every population, but certainly with this. And Mickey's now housed, and that's Jill doing her home visit. The other thing we've learned is you can do an awful lot of primary care. So we've challenged our folks at Mass General and at Boston City to think of what happens in a primary care office that you can't do outside if you know somebody. And it turns out to be very, very few things. Mostly it's imaging and blood tests and stuff, but everybody gets a flu shot, everybody gets a pneumovax, everybody gets mammograms. And when we skip over this, we